Hello everyone, my name is Dr. Hani. I am a senior lecturer from University Malaysia Sabah. Today I am going to talk about the chronic renal failure. At the end of this module, you will be able to understand what is chronic renal failure, what are the stages in chronic renal failure, the causes, clinical features and complications of chronic renal failure. Last but not least, investigation and how to manage the chronic renal failure patients. Chronic kidney disease is defined by the irreversible deterioration of a kidney function. Kidney function the reduction is necessary to be persistent for 3 or more months in order to be able to differentiate from acute kidney injury. End-stage renal failure is characterized by the chronic kidney disease which need to be treated with a renal replacement therapy, either hemodialysis or renal transplant. In the chronic kidney disease patient, we need to check the glomerular filtration rate and creatinine clearance level. In order to check the either GFR or creatinine clearance level, we need to measure the creatinine level. And some of the laboratory, they have a automatic calculation for the creatinine clearance and GFR. When you look at the urea level will not be raised until the kidney function is deranged more than 60%. So that we don't rely on the urea level in order to define this is a kidney failure. So these are the stages of the chronic kidney diseases. In the stage 1, you will see the kidney damage with normal GFR, you can see it. In the stage 2, GFR slightly reduction, 60 to 89 with kidney damage will be present. Starting from stage 3, with or without the kidney damage, GFR is moderately reduced, less than 60 ml, which is starting to be defined as a chronic kidney disease stage is starting. And stage 4, severe reduction in the GFR less than 30. In that stage, you need to refer to the nephrologist for renal replacement therapy. Stage 5, end-stage renal failure, already GFR less than 15 ml, and patient need the renal replacement therapy. So let's look at the 3C. Number 1C is the causes of kidney failure. There are reversible causes and irreversible causes of a chronic renal failure. Why we need to know the chronic renal failure causes is we need to correct the reversible causes of these conditions. The commonest cause in Malaysia is a diabetic nephropathy, hypertension, nephropathy, glomerulonephritis. If patient have a family history of the kidney disease, then we will consider the polycystic kidney disease. In young female patients, if kidney function is start to be deteriorate, we need to watch out for the connective tissue diseases such as SLE, systemic lupus erythematosus. And other causes are obstructive uropathy, HIV nephropathy. In child, we are considering about the reflex nephropathy as well, and pyelonephritis and renal artery stenosis. When you look at the kidney function, there are basic 4 functions of the kidney: filtration, reabsorption, secretion, and excretion. When the blood is coming from your afferent arteriole, the glomerulus will filter the blood. Then whatever filter will be coming to your Bowman capsule and tubules and coming as a urine. But whatever not being filtered will go back to your blood circulation by the efferent arteriole. Apart from these functions, the kidney has another function, which is a hormone production, erythropoietin, which is necessary for synthesis of the hemoglobin. So let's look at the chronic renal failure patients. When the kidney function is deranged, the number 1 first function of a fluid and electrolyte balance. So if in the kidney failure patient, fluid retention will be happen because of derangement of the fluid balance, and it will be manifested as a edema, ascites, and complicated as a acute pulmonary edema. If electrolyte becoming imbalanced, H plus will be retention in the body, which will trigger the metabolic acidosis. Other electrolytes such as sodium will be retained in the body and which will trigger, together with the fluid retention, end up in the edema and acute pulmonary edema, heart failure, and cardiovascular diseases. Potassium cannot be secreted and it will be retained in the body, and patient can complicate it with a hyperkalemia, which will be manifest as a palpitation, weakness, and arrhythmia. In the filtration, protein cannot be retained in the glomerulus, and a lot of protein will be lost in the urine, end up in the proteinuria, which will be manifested as a frothy urine. If a lot of proteins are lost from the body, immunoglobulin, lipoprotein function derangement, which will be end up in the coagulation defect, dyslipidemia as well. Excretion urea will be retained in the body, and urea complications such as uremic pericarditis, uremic gastritis, and platelet dysfunction, which will be manifest as the bleeding. And finally, uremic encephalopathy can be complicated. If erythropoietin cannot be synthesized from the kidney, patient will be complain of the anemia symptoms such as palpitation, reduced effort tolerance, pallor, fatigue, and end up in the anemia, heart failure. One of the major manifestation of the chronic kidney disease patient is there is a phosphate retention in the body and reduced calcium because of the reduced calcidiol. So there will be a secondary hyperparathyroidism and renal osteodystrophy. Manifestation of the renal osteodystrophy are osteoporosis, osteomalacia, and calcium deposition in the soft tissues. So when you look at the main principal treatment of the chronic kidney disease is you have to slow down the progression of the chronic kidney disease. So one patient presented with the coming up for the medical checkup, no symptoms. Normally we check up for the urea and creatinine. Importantly is a creatinine because urea can be still normal once creatinine start to be deranged already. So screening for the chronic kidney disease in risk factor patients such as hypertension, diabetic, SLE, HIV patients. So if we find out that after the screening of a chronic kidney disease by the creatinine level and GFR level, if there is an increased risk of a chronic kidney disease is possible, you have to prevent the damage of the kidney damage by treating the underlying cause, treating the risk factor as well to slow down the progression of a chronic kidney disease. In order to diagnose the investigation of chronic kidney diseases, basic investigation coming for 3C. To look for the causes of a chronic kidney disease, you might need to work up for the connective tissue diseases, fasting blood sugar level, HbA1c. For polycystic kidney disease, you need to do the genetic study or ultrasound to look for the polycystic kidney disease. In order to confirm, you need to do the GFR, glomerular filtration rate, creatinine clearance, and urine FEME to look for the proteinuria. In order to look for the complication of the chronic kidney disease, you need to do the investigation for electrolytes such as potassium, calcium, phosphate. Potassium will be high because of the hyperkalemia, hypocalcemia, and hyperphosphatemia. If the patient have a hyperkalemia, you will see the ECG changes such as a tall tentative wave, white QRS complexes, prolonged PR interval, and severe hyperkalemia patient, you will see the sine waves. ABG, there will be metabolic acidosis and reduced bicarbonate level. In full blood count, you will see the normochromic normocytic anemia. Hormonal imbalance such as a secondary hyperparathyroidism, so parathyroid hormone level will be high and vitamin D will be low. If you do the ultrasound KUB for chronic kidney disease patient, you will see small kidney size and loss of corticomedullary differentiation. In some conditions, you will able to see the normal kidney size in diabetic patients, amyloid nephropathy, or multiple myeloma cases. Pharmacological conservative management in the early stage of the chronic renal failure. You have to treat the underlying cause of the chronic renal failure, reversible causes, and you need to prevent or treat the complications. In non-pharmacological management, especially is a diet therapy, you need to educate the patient and refer to the nutritionist as well to calculate the protein restriction, sodium restriction, phosphate restriction, and potassium restriction. And patient need to educate to take the adequate intake of the calories. Very importantly, you need to educate the patient to avoid the nephrotoxic medication such as NSAID, non-steroidal anti-inflammatory medication for painkiller. In the complication, if patient complicated with the hyperkalemia, you need to start the lytic cocktail therapy or hemodialysis. If patient have a persistent hyperkalemia, in fluid overload patients, diuretic will work. If persistent fluid overload, dialysis will be working. In patient with the anemia, initially iron therapy. If persistent anemia or anemic heart failure or a complicated anemia, then erythropoietin injection will be work. In patient with the renal osteodystrophy and hyperphosphatemia, calcium carbonate, vitamin D. If patient persistent secondary parahypothyroidism, parathyroidectomy have to be arranged as well. As patients are going for regular hemodialysis, patients need to be immunized hepatitis B vaccination before they go for the hemodialysis. As the chronic renal failure patients are very prone to get the cardiovascular disease and cardiovascular mortality is very high, so patient need to start the statin therapy if there is a hyperlipidemia. When we look at the end-stage renal failure patient, they might need the renal replacement therapy. So indication for renal replacement therapy are GFR less than 10, which is a stage 5 renal failure, or uremic syndrome, hyperkalemia, acidosis, fluid overload. These are the complications of a chronic renal disease patients. Remember, when you are starting the hemodialysis or renal transplant for those who have a chronic kidney disease, the hemodialysis will able to minimize the symptoms by removing the fluids and maintaining the electrolytes from your circulation. But it won't replace the endocrine function and some metabolic functions such as vitamin D, calcium level, and phosphate level. There are 4 major methods of renal replacement therapy: hemodialysis, peritoneal dialysis, hemofiltration, and renal transplant. Hemodialysis, usually there is a AV fistula or graft or IV catheter, central catheter, either IJC or femoral catheter. There are complications such as hypotension after the excessive removal of the fluid from the body. Patient can got the line-related sepsis if patient have a central line. Bleeding can be happen because of we use a heparin during the hemodialysis. Long-term complication of the hemodialysis can be amyloidosis or neuropathy or heart diseases. And if patient have a fistula or graft in the hand, this can be complicated as a venous stenosis or venous thrombosis. In the peritoneal dialysis, there is a 2 method, either continuous or intermittent. Indications are especially the very young age, child age, or very old age with the cardiovascular disease, because when they go for the hemodialysis, they cannot tolerate the excessive removal of the fluid from the circulation within a few hours. And complications can be hypovolemic shock can be still happen in this peritoneal dialysis. Peritonitis is a very common Because of that, we need to make a incision in the abdomen. There will be an incision hernia can be happen as well. Encapsulating peritoneal sclerosis, abdominal pain can be happen if patient dialysis is a too cold or acidic condition. During the insertion time, bowel injury and bleeding can be happen. Renal transplant. There are some absolute and relative contraindication. If patient have an active malignancy or active vasculitis or severe heart disease patients or very old age patient, this will be relative contraindication. Complication of the renal transplant can be complication from the renal transplant itself or complication from the medications, immunosuppressants. Thank you very much.